On behalf of the Texas Primary Care Consortium, we warmly welcome you to our webinar on primary care. We are so excited to share our passion for primary care with you and to learn from you as well. Primary care is the key that has the power to unlock health, the health of individuals and communities. Next slide. We are most grateful to our generous supporters, Texas Academy of Family Physicians and the Texas Medical Foundation Health Quality Institute for supporting this webinar. Next. And thanks to our partners for supporting the important work that we do to advance primary care in Texas. Next. We are a statewide collaborative initiative whose mission is to advance equitable, comprehensive, and sustainable primary care for all Texans. Now, before we begin, a brief housekeeping item. Please use the chat function for comments or technical assistance. And please input questions in the Q&A box. Next slide. Well, today we'll dive into the history of primary care, and we'll also cover what research tells us about its potential. We'll talk about the obstacles to achieving its potential, along with possible solutions with a special focus on Texas. Next slide. My co-presenter today is Nishi Singhal, who recently joined the TPCC team as program officer. Nishi brings a wealth of experience in health systems and accountable care organizations from her native Michigan and Chicago. We are thrilled that Nishi is part of our team. I'm Sue Bornstein. I'm an internal medicine physician and executive director of the Texas Medical Home Initiative and co-lead of the Texas Primary Care Consortium. Now, before we start, I do want to offer a disclaimer. Primary care and its role in our health and healthcare is a very broad and very deep topic. Time just does not allow us to discuss every aspect of primary care, but if there are specific areas you'd like to know more about, please do let us know. And speaking for Nishi and me, I think we'd love to do another webinar. Next slide, please. Well, what is primary care? I think that it's really important to start with a shared understanding of what we mean. Well, there are many good definitions out there, but we think that this is one of the best. This definition was used most recently in the 2020 National Academies of Science, Engineering, and Medicine report on primary care, and I am going to read it. There's a lot packed in here. There's a whole lot of different themes and threads packed in here. High quality primary care is the provision of whole person, integrated, accessible, and equitable healthcare by interprofessional teams who are accountable for addressing the majority of an individual's health and wellness needs across settings and through sustained relationships, patients, families, and communities. And we should note also for completeness that primary care encompasses family medicine, geriatrics, internal medicine, obstetrics, gynecology, and pediatrics. Next. I actually wanted to say this on the last slide, but I'm going to go ahead and say it now. And I think it's important just for historical context to understand that the concept of primary care is really relatively new, dates back probably to the 1920s. It's first thought that it was mentioned in the United Kingdom with the founding of the National Health Service. But it's something to keep in mind is that prior to the 1930s, most physicians in the United States practiced general medicine or surgery. The specialization really arose mainly after World War II. And so that's something to keep in mind. I mentioned the NASM report. The NASM report is a very important watershed, and I think in our understanding of primary care. And it outlined 5 objectives for high quality primary care that really guide our work and the work of others that are committed to strengthening primary care. And you will see these recommendations reflected throughout the rest of the presentation, but I just want to briefly go through them. The first recommendation, pay for primary care teams to care for people, not doctors to deliver services. And if you think about that, that is a pretty groundbreaking idea. I think historically, the physician was paid for the care that was delivered and then moved on to the next patient. So this really looks at a whole different way of not only paying for care, but delivering care. So that's pretty foundational. The second one, ensure that high quality primary care is available to every individual and every family in every community. This really speaks to health equity. And I'm going to talk a little bit more in a moment about the importance of health equity in primary care. The third is to train primary care teams where people live and work. Well, we know that it's very important we have better health outcomes when primary care teams reflect the patients that they are caring for. The fourth, design information technology that serves the patient, family, and care team. And for those of you that are involved in clinical care and that work with a electronic health record, probably this will hit a nerve with you too, because I think it's safe to say that the majority of health information technology systems are really not designed for primary care or for patient-centered care. And finally, ensure that high quality primary care is implemented. And what this really refers to is the belief that one of the things that is needed at the federal level and probably also at state levels is an agency as a council to oversee primary care. And no such thing exists right now. So part of the NASM report is to ask Health and Human Services to create a council on primary care for a couple of functions: to oversee the cost of primary care, utilization of primary care, also to sponsor research in primary care, and to develop scorecards about primary care spending in particular. Next, please. So I mentioned, I think history is important, and I think that this is something that we need to think about when we think about primary care and where we are today. So in 1978, the World Health Organization, UNICEF, held an international conference on primary care in what was then Alma-Ata, Russia. It's now in Kazakhstan. 134 countries were represented. And the work product of the Alma-Ata conference was the declaration. And this was groundbreaking. This recognizes primary health care as a means to achieving health equity for people of all nations. Next, please. Thank you. The declaration further stated that primary care forms an integral part of both the country's health system and overall social and economic development of the community. And this, again, this is important because it recognizes that primary care is an essential element of achieving health equity, specifically when every person has the opportunity to achieve his or her full health potential. Next, please. A great deal of what we know about primary care is derived from the work of Dr. Barbara Starfield. Dr. Starfield was a pediatrician by training, and she devoted her entire professional life to advancing primary care through research, both in the United States and internationally. Her 2005 paper, Contributions of Primary Care to Health Systems and Health, really broke new ground with these findings. Health is better in areas with more primary care physicians. People who receive care from a primary care physician are healthier, and characteristics of primary care are associated with better health. Next slide, please. Well, what are those characteristics? Well, Dr. Starfield identified the 4 C's of primary care. First, contact, coordinated, comprehensive, and continuity. So let's look into those each individually. So first, contact, she means that primary care practice really should be accessible. This is key to the success of primary care, accessibility. And the primary care office should be the first place that one thinks of when they need care. Coordinated. This characteristic is more important now than even in Dr. Starfield's time. There was a fascinating study in the Annals of Internal Medicine in 2009 that found that the typical primary care physician has 229 other physicians working in 117 practices with which care must be coordinated. And I can assure you, having been a primary care physician in practice, that does not just happen by itself. That requires systems and a high degree of involvement of the staff. Comprehensiveness, the idea is that practices should strive to provide the majority of care needed by their patients. And finally, continuity. We know that high quality primary care is longitudinal in nature. Patient establishes a long-term relationship, the practice, rather than simply having transactional relationship. Next slide, please. Now, recently, some primary care scholars have suggested that in order for primary care to achieve the goal of health equity, we need to consider adding 5 additional C's: convenience, cultural humility, structural competency, community engagement, and coordination. And so convenience, well, think about transportation challenges that your patients have. They pose barriers to access. Cultural humility. We live in a richly diverse society, and in order to provide optimal care for our patients, it's really important that we approach each individual with humility and a sense of cultural curiosity. Structural competency refers to the fact that in an era of increasing specialization, it's really important for primary care clinicians to maintain and hone their skills in caring for primary care type illnesses, conditions. Community engagement, the recognition that social determinants of health contribute more to a person's status than medical care, and establishing connections with food banks, housing agencies, employment agencies, and the like is important, as is collaboration across a wide range of groups. The authors also stress the primary care workforce needs to better reflect the patients we care for through purposeful recruitment, hiring, education, and training of teams to reflect the demographics of the population served. And a really sobering statistic is that percentage of Black male doctors in the United States, both in 1940 and 2018, was about 2.7%. So let that sink in for a minute. And this is, of course, despite significant increases in the Black population during that time. So clearly we have a whole lot of work to do in terms of our workforce. Next slide, please. Thank you. Well, I'm going to give you another disclaimer, and that is that an in-depth discussion of the patient-centered medical home is really not possible in this webinar, but that does not diminish and should not diminish its importance in the evolution of primary care in the United States. And just again, for a little background that I think may help us understand the concept better. The medical home idea was created by pediatricians in the 1960s. And referred to the need for really a central repository for medical records, especially for children and youth with complex healthcare needs. And implied in this concept was that the practice should be familiar with that child's medical, surgical, and social history. And the concept gained traction in the adult medicine community in the mid-2000s. And one of the architects of the medical home is Dr. Paul Grundy. Also sometimes called the godfather of the medical home. Dr. Grundy was then the chief medical officer for IBM, the multinational international corporation. And as chief medical officer, he was in a really unique position to see the differences in cost, quality, and outcomes for IBM employees living abroad compared to those in the US. And he realized that in general, care in the US was more expensive, and of uneven quality, and sometimes yielded inferior outcomes. So this really propelled him and other corporate leaders to join with payers and primary care physicians to champion the patient-centered medical home. The joint principles were adopted in 2007 by the pediatricians, internists, family docs, and the American Osteopathic Association. And you know probably the rest of the story. The NCQA then developed standards for the medical home beginning in 2008. And many practices joined the PCMH movement and started the process of transforming to medical homes. At that time, there was a lot of activity. There were many practices that were part of multi-payer collaboratives, like in Colorado, Pennsylvania, Rhode Island in particular. I will share with you that one of the enduring challenges and impediments to the medical home movement has been the lack of associated payment reform. And we'll talk more about this in a few slides, but without a different way to pay for primary care and the transformation that's required to sustain it, the medical home movement really has not reached its potential. And another barrier to the success of medical home is the differential timeline that is envisioned for savings and for improvement in measures that most funders want, a 1 to 2 year timeline, where most experts on practice transformation think that a 5-year timeline for beginning to bend the cost curve is more realistic. So that is one of the tensions. But I will say that one of the enduring benefits of the medical home movement is the establishment of the Primary Care Collaborative, formerly the Patient-Centered Primary Care Collaborative. And this multi-stakeholder organization really has contributed significantly supporting primary care transformation through education and research. Next slide, please. Take a sip of water here. Well, all of us are aware that the COVID pandemic really shone a very bright and unflattering light on the US healthcare system. There were glaring health inequities in terms of the prevalence and morbidity of infection, with historically marginalized groups having worse outcomes. There were also challenges with equitable vaccine distribution and testing. Primary care practices struggled to survive in a new world and to meet the needs of their patients through telemedicine, vaccination clinics, et cetera. Vaccine storage was a major obstacle initially. And we know from really good data that unfortunately, chronic disease management and cancer screening and follow-up were major casualties of COVID. Also, the prevailing model, fee-for-service, which we'll talk about a little bit in a minute, and lack of infrastructure investments left really no safety net for practices who were unable to see patients or care for patients in the traditional way. And added to that, an aging physician primary care workforce led to many considering retirement or just leaving for other settings. And not surprisingly, rural Texas communities were particularly hard hit by COVID. And as we'll point out later, typically have less access to primary care, are generally older, sicker, and poorer. So all these factors really reinforce and underline the need for a robust, nimble, well-funded, and well-staffed primary care system. Next slide, please. Well, early in the pandemic, actually in March of 2020, so that is early, that was really the second month, the Larry Green Center and the PCC began a biweekly primary care survey. And these reports chronicle the impact that COVID has had on practices, their staff, and their patients. And this is just a screenshot from the last survey that was done just in March of this year, and it showed nearly half the clinicians surveyed say that primary care is crumbling. Wow, 40%. Half, over 40% say that they're mentally and financially fragile. And that is 2 years into the pandemic. Fewer than a quarter practices report being fully staffed. So this series, this may be one of the most important data points that we have, data sets that we have about primary care. And if you read these reports, they really tell us what we need to do. They tell us where the reform needs to happen. Next slide, please. But being in the eternal optimist that I am, and I think all of us that are engaged in this work are, there is a very bright side to this gloom. And this graphic was also from the Green Center. And so 77% of practices during the pandemic provided more mental health support than before. 69% used telehealth to meet patient needs. And you have to remember that there are many, many practices that prior to the pandemic did not have really any significant ability to provide telehealth services to their patients. And there are some really miraculous stories of practices learning over a weekend how to pivot to telehealth. And so, and also 28% of the practices surveyed show that they increase their support for their patients with food insecurity and more. And so to me, this is really the promise of primary care. This is meeting the needs of our patients in really unprecedented circumstances. Next slide, please. So why is primary care important? Well, I think we've already hit on that to some extent, but we're going to look a little more detail at some of the specific issues, challenges, access challenges, increasing cost, worsening chronic disease burden, and widening health disparities. Next, please. But before we start, that discussion, I want to share a fundamental and powerful truth about primary care. Primary care, when prioritized in the health system, results in people living longer lives with more equitable outcomes. And Dr. Starfield's work taught us that in communities with strong primary care presence, there were lower rates of cancer, heart disease, preterm birth, and lower all-cause mortality. And I will say to you, primary care is really the only component of our healthcare system about which this can be said. So that is something to always keep in mind. Next, please. So access to care is a significant challenge for many, and Nishi is going to share some Texas specific data in a few minutes. But I think it's important to realize that about 65% of US physicians are specialists, 35% are primary care doctors. And this is the absolute inverse of most countries to whom we compare ourselves. And those countries typically tend to have healthier people and lower costs. Further, and very concerning, is that Americans are less likely to have a long-standing relationship with a primary care practitioner, and less likely to be able to see a primary care physician after hours. And we know that the ability, whether it's electronically or in person, we know that the ability to see a primary care practitioner after hours can really result in avoiding hospitalizations, avoiding emergency department visits, et cetera. So access does remain a significant concern. Next, please. Well, you've all seen this graphic, but it points out one of the biggest problems in US healthcare. We spend more money. We spend far more money on healthcare by far than any country in the OECD, which is the Organization of Economic Cooperation and Development. And these are the countries to which we compare ourselves. We spend about 18% of our gross domestic product on healthcare. The next highest is Switzerland at 11%. So why do we spend so much on healthcare? Well, it's complicated and there's a lot of different factors, but administrative burden in this country is a major issue. Pre-authorizations, things like that, multiple formularies, multiple measures of quality from different payers, less robust primary care. We've certainly talked about that. Higher hospital costs and drug prices are a few of the reasons. And next, please. Well, just as important is as the amount of how much we spend is where the money is spent. And as you can see, only about 5 to 7% on average of the healthcare dollar is spent on primary care services. The largest piece of the pie, the dark blue or purple on the right, it goes to hospital costs, 38% hospital costs, and prescription costs are 14% approximately. So that's twice as much as we spend on primary care. Now, if you stop and think about that just for a minute, I don't think it's really a stretch to say that if we had more investment in primary care, hospital and drug costs just might be less as well. Next, please. Thank you. This is another contributor to the high cost of healthcare. This really staggering number of Americans living with one or more chronic conditions. 60% have at least one. This is adults. 60% have at least one. 40% have more than one. 12% have 5 or more chronic illnesses. And if you think about this, just step back into the early 1900s, people didn't live long enough to develop chronic diseases. So if you developed congestive heart failure, let's say, you more than likely were not going to survive very long. Same thing with type 1 diabetes. That was an acute illness that almost always ended in death. So the whole evolution or the whole presence of chronic illnesses is really something relatively new. Next, please. This slide shows that with higher primary care spending, there are fewer avoidable hospitalizations. And we know the primary care is associated with fewer hospital admissions for what we term ambulatory sensitive conditions. And those are things like asthma, diabetes, and heart failure. These conditions are typically best treated in the office, thus avoiding hospitalization in many cases. Next, please. Well, fundamental to the US health system woes, in my opinion, is the persistence of the fee-for-service payment model. And this is especially true for primary care. So strong primary care requires not only face-to-face visits, but intra-visit care, coordination, family conferences, specialist referrals and follow-up, medication reconciliation, follow-up of testing, and care planning, working within the team, working within the interdisciplinary team, having team meetings, having huddles before the beginning of the day and at the end of the day. And fee for service, which is based on transactional medicine. In other words, you have an acute problem, you come to the doctor's office, you get treated, and you go on your way. That is supported by fee for service, but the fee for service does not adequately support the other important functions. We are paid for quantity over quality, volume over value. And really, somewhat disappointingly, the move towards payment reform has been rocky. And the majority of payments for primary care are still fee for service. And again, until we move toward a more global way of paying for care, we will not achieve the potential of primary care. Next, please. Thank you. We talk a lot about value-based care. And again, that's one of those that could take a whole hour or two or three to talk about. But here's a brief overview of some of the major ones. Accountable care organizations, which probably most people are familiar with, networks of physicians, hospitals, other providers that get together to provide quality care, and the ability to eliminate redundant or unnecessary care, focus on disease prevention, et cetera. And so ACOs have been, in many cases, very successful. The ones that have been the most successful in terms of finances and outcomes are the ones that are physician-led. Bundled payments are another type of value-based payment. This is probably more suited for surgical specialties. For example, a total hip replacement. There can be a bundled payment where the surgeon gets part of it, hospital gets part of the payment, and whoever else, the primary care physician, gets it. So that has a place, but it's sort of a niche. And then the patient-centered medical home, as we talked about previously. So I've talked a lot, and you're probably at this point, no doubt, ready to hear from my colleague Nishi. And Nishi is going to explore some Texas-specific data, and she's going to share what the Texas Primary Care Consortium is doing to advance primary care in Texas. So Nishi, take it away.
Thank you, Dr. Bornstein. I could hear you speak for much, much longer. Thank you, everyone, for being here. So as Dr. Bornstein said, we're going to start talking about primary care performance specifically in Texas. But as I go through the next few slides, there will be lots of numbers, lots of different stats. I definitely want us to keep in mind what we've talked about so far. I think the hard-hitting fact for me that I've learned so far is definitely that primary care, when prioritized in the health system, results in people living longer lives with more equitable outcomes. And so as I go through the next few slides, these are going to be unfortunate numbers that are representing Texas, but I just want us to keep that in mind, what we've learned so far. And of course, after I go through the Texas primary care performance data, we will talk about, well, what are we doing about all of this? And of course, answer questions that you all might have. So this first slide that you see, we're talking specifically about access to care. So we know that over 5 million Texans are uninsured, and we actually lead the nation in the number of uninsured. We're twice the national average. I really like this fact that the uninsured status is one of the biggest drivers in preventing individuals from seeking primary care. So knowing, the high number of uninsured Texans that we have, and knowing that that status is really preventing people from seeking primary care, I think that's definitely something that we all need to digest. And breaking this down by race, 27% of Hispanic Texans are uninsured, and this is compared to 12% of non-Hispanic whites and 18% of non-Hispanic Blacks. And along the Texas-Mexico border, rates of uninsured actually exceed 30%. This graphic that we see to the right, this actually comes from one of our produced reports that I'll talk about in a couple of slides, but this is a pretty great graphic. It basically shows the uninsured rates in Texas varied by region, broken down by race and ethnicity. So that's a report that I'll talk about in a couple slides if you do want to study that a bit more. We'd be remiss if we didn't talk about rural Texas, because we have 3.8 million Texans that live in rural areas, and this is more than any other state. We know that rural Texas residents tend to be older, poorer, and suffer from more chronic diseases. They also face more significant challenges in accessing preventative, acute, maternity, and chronic care services. And we also know that there's a huge shortage in primary care providers. So these numbers are pretty crazy if I sit down and think about them, knowing that 32 counties out of 254 counties don't have any primary care providers, and 75 counties don't have any PAs, and knowing that 28 counties have neither primary care physicians or PAs. Texas is also leading the nation in rural hospital closures. So since 2010, there have been about 26 hospital closures in 22 communities. And looking at utilization and health outcomes in Texas. So every year, the Commonwealth Fund has a scorecard that basically ranks all states in the country. This year, Texas has ranked 48 out of 51 on the scorecard. So the scorecard measures access, affordability, rates of insurance coverages, cost-related barriers to receiving care, and rates of medical debt. Texas also has a higher preventable hospitalization rate than the rest of the country. Give me 1 second. There we go. And now talking about costs, from the same Commonwealth scorecard, Texas has ranked last in the country in access and affordability, and 40th out of 51 in avoidable hospital use and costs. And we also know that 15% of Texans went without care because of costs versus 10% nationally. And so now we are going to talk about Texas Primary Care Consortium a bit more, looking at our efforts and taking a bit of a breather from some of these numbers. Essentially, we know, so far from our presentation, we know that primary care is very, very important. We know that we have many needs. Being in Texas, we know that there are many needs that we want to address here. So what already is occurring? What are we doing about this? And what can keep going on? So Dr. Bornstein has already described who we are, but just to state this again, the Texas Primary Care Consortium, we're a statewide collaborative initiative with a mission to advance equitable, comprehensive, and sustainable primary care for all Texans, led by the Texas Medical Home Initiative in partnership with the Texas Health Institute. We also have this great framework from which we lead. And so there are 3 big buckets. We have transform, educate, and activate. I'll start with educate, since it's really because of this educate category that we are presenting that we have this webinar. And so we are expanding our knowledge base by sharing best practices, lessons learned, and tools. The activate bucket, we're facilitating opportunities to build and strengthen lasting partnerships for shared and sustainable impact. As Dr. Bornstein shared at the beginning of the webinar, we have many, many great partners that help fund our work, that we work with. And anything and every project that we do, of course, everything is evidence informed, but it's also consensus based as well. The third bucket, transform, we're creating spaces for dialogue and action to generate a shift in the healthcare system through policy and system change initiatives. I will be going through some policy work that we've actually been starting to engage in this year that would be an example of this. And so from that educate button, I wanted to highlight a couple of reports that we have, just two of many resources that we have. And we have actually a web link at the bottom. I believe someone is also putting that in the chat as well, txprimarycareconsortium.org/resources. We have many, many great publications, blog posts, an interactive dashboard that I'll actually sharing in just a slide. But one report that had come out in September 2020 was about COVID-19 in Texas. So focusing on uncovering the racial inequities and advancing health equity in response and recovery. This report that's towards the right, Making Primary Care Primary, Prescription for the Health of All Texans. This is a report that the graphic that showed the uninsured rates in Texas broken down by region, race, and ethnicity. It did come from this report. I will say that because you all are attending this webinar, I think that you will find this report very, very interesting. This report provides a data-driven, evidence-informed, comprehensive understanding of key issues essential to advancing primary care and health system transformation. So I think in order to check out that report, and of course, many of our other resources, definitely feel free to visit our website. And this is a dashboard that I was just mentioning. It's called the state of primary, or what is the state of primary care in your county? Again, the hyperlink is down below, but it is also being shared in the chat. I do want to take a second to actually share this dashboard with you so you can see what resources it could provide you. So give me 1 second. And so right now you see our website, and on our website, we have a button here called resources. So under resources, if you click this button called interactive tools, it will bring you to our data dashboard. So again, what is the state of primary care in your county? So this is a dashboard that we created well before my time, so I can take no credit for this. But this is using existing national and state data sources. Basically, it's a broken down profile of every county in Texas. There's over 50 measures that are across 6 domains, which you see here: demographics, health needs, facilities, workforce, health behaviors. And again, we have this for every single county in Texas. So once we click Find Your County, this opens up into the map of Texas. And as I hover my cursor over the state, you see all of the counties listed here. I will go ahead and click on Reeves County so I can show you what this looks like. Again, at the top, you see the 6 domains with all of the measures spread across these 6 domains. So if I click on health needs, this will take us down into the health needs section. And yeah, there's just a lot of really great data here. I actually have not even explored this much myself, but every time I look at it, I know that this is something that would be very helpful for me to spend more time on. The demographics section, if we click on this down arrow, this will help us see the breakdown of our demographics by color and race and ethnicity. Back to sharing our presentation. And please let us know if you have any questions on that. You can share that in the chat. Now talking about our policy work. So starting this year, we have developed our objective of developing and implementing a coordinated advocacy roadmap to prioritize primary care during the upcoming legislative session. And really, this is, of course, for the goal of increasing primary care access and investments in Texas. So bringing this back, to what we've learned so far during this presentation, we do know now that, increasing access to primary care, investing more in primary care will better the health of all Texans. And so since the beginning of the year, we have been meeting with a variety of stakeholders representing the primary care universe, again, really coming back to this idea of wanting to be consensus-based. There are so many great ideas out there. We have been even learning from other states as well, what has worked in other states, even what hasn't worked in other states, what has worked in Texas, what hasn't worked in Texas. But we really want to make sure, as I was going to quote a quote that I actually can't even think of right now properly, but if you want to go far, it's better to go together. So everything we do consensus based. And so we're coming to a close on those meetings, starting to detail out what our actual policy asks will be so that we can then go to policymakers starting this fall. And so some of the policy areas that we've been exploring, you see on the slide: telehealth, value-based payment models, supporting the primary care team, reducing administrative burden on providers, and then of course, patient-centered medical homes. And then last but certainly not least, our annual summit is actually occurring next week. So it is September 8th and 9th in Austin. What's very exciting is that this is our 10th annual summit. So we will be celebrating a decade of powering primary care transformation. The summit is truly the centerpiece of what this consortium has done and what it does do. I have a slide with a couple pointers. So CMEs and CNEs will be provided. Because this is our 10th annual summit, there will be an inaugural Primary Care Champion Award. Our keynote is on the past, present, and future of primary care. So again, since you're attending this webinar, I think that opening session will be of interest to all of you. There are breakout sessions on topics like health literacy, behavioral health, which is something that we didn't get to today, but it's a vital component of primary care, value-based payment models, and then of course, telehealth. I want to pause here and just check in with Dr. Bornstein. The summit has been, such a vital part of our work. And actually, this will be the first one that I get to attend. And because it's happening in person, which is also very exciting, checking in with Dr. Bornstein if there's anything else you wanted to add to this.
We just want to see everybody there. And hopefully this webinar has piqued your interest in certain things. And as Nishi mentioned, when we were looking at our slides, or reviewing our slides, I thought, we really didn't get a chance to talk about the importance of integrated primary care. So behavioral health and oral health and substance use disorder and the like. And so those topics will be covered at our summit. So somewhat shameless plug, but again, as I put in my first disclaimer, this is a whole lot to cover, but there's, it's good. It's a good problem to have, because, you look at one thing and you think, okay, well, what about this issue? What about this issue? So, and again, that's what we do. And that's why we're here. And as she said, we're just absolutely thrilled to be back in person for our 10th anniversary. And it's going to be very special. There's going to be some very special moments. So we really do hope to see as many of you there as possible.
Yes, I am excited. And so I just wanted to share this as well, what our partnership opportunities are, because, as we've shared, we are a multi-sectoral network. All of our work, we really like to work with a variety of stakeholders or a variety of partners. So what do you get by joining our network? You leverage our TPCC network to advance state and local policy actions. You get to access timely updates and communications tailored for your network, be the core driver in expanding and strengthening the primary care workforce, which we know is vital to primary care, and connect with other statewide primary care stakeholders. So if you are interested, again, we have a link at the bottom on our website, and I believe it's also in the chat as well, where you can learn more about what does it mean to be a partner. There's 3 different levels, and of course, let us know if you have any questions. And just lastly, thank you so much for joining us today. Please follow us on Twitter at TXPCC. We also have a Facebook page at Texas Primary Care Consortium, and we have a very, very wonderful newsletter. You can subscribe by going to our website, and you can also, of course, contact us there if you have any questions for us as an organization generally. But I have listed Dr. Bornstein's email and my email here on the slide. If you want to reach out to us individually, say hi, introduce yourself. We love new friends, so please reach out. And we do have, actually, it's great. We have about 15 minutes left for questions, and I do see some questions coming through. And so as I bring up these questions, Dr. Bornstein, we actually did have some questions submitted beforehand that I will read off one of them, which I really appreciated. Primary care has taken a hit during the pandemic. What can the legislature do to get Texans to return to primary care?
I think that's a really good question, and I think there's a lot of different components to that. Part of the challenge that we have is our messaging, right? What is primary care? What is the value of primary care? And so, if you're a young person that maybe feels great, you don't have any illnesses, you don't have any chronic conditions, you're probably not going to necessarily think it's important to establish a relationship with a primary care practice. But we're all going to get older, hopefully, and we're all going to develop some type of acute or chronic problem along the way. So I think that the question raises an issue, which is I don't think we've messaged properly, and honestly, that is part of the policy work that Nishi talked about. Is how do we craft the message so that our legislators, our policymakers hear it? Now, it may be that it's a cost thing. We look at primary care; it saves money. I mean, that for some people, that's a compelling reason. To me, it's like it produces healthier people and healthier communities. So I think that it's a very good question, and it's one that we continue to ponder. I also think that not having copays to see a primary care physician, or practice. And when I say practice, I mean physician, but I also mean practitioner. I mean nurse practitioner. I mean PA. So the practice is sort of the generic term. So by no means do we want to exclude anybody that's on the healthcare team in this. So please understand that. So yeah, maybe limiting copays. That's one thing that some payers have done in order to get folks to be more incentivized to go to see a primary care. So I think there's not one easy answer, but it certainly is something important. I mean, the data about cancer screening and people developing cancer is very alarming. And so, yeah, we definitely need to get back in the game. Good question.
Thank you. There was a question that had come out on the chat today by Clayton Travis. What can the state do to incentivize Texans to seek out early and ongoing primary care?
There you go, Clayton, my friend Clayton. Again, I think, Clayton, this is related to the last question, and that is, what is the messaging? How do we convey the value of primary care to the person that the average person, to the population? How do we convey that? And so I think working with folks like you, Clayton works in policy for the Texas Pediatric Society. Let's talk to you all. Let's talk to the family docs. Let's talk to the OB-GYNs. And how do we message this? And so I think there's a lot to be gained from the collaboration that we all have and have all developed. And I'll just have to say that I think, to me, that's one of the best things that has happened with this consortium, is that I think that the primary care players in this state are more connected than we have been in the past. That can only be a very good thing. So it's a work in progress. And I know that's not a specific answer, but hopefully that'll give you some ideas.
This was a question that was submitted beforehand, and I knew I had to ask you, Dr. Bornstein. How do we promote the importance of the medical home?
Yeah, again, and I hope that no one thought that I am not a supporter of the medical home, because I absolutely am a supporter. I will always be a supporter of the patient-centered medical home. My comments were intended to maybe respond to what people are thinking. Well, what is the status of the medical home? Well, maybe we don't hear about it as much as we had. I think that what we're seeing really is kind of an evolution. And again, another semi-shameless plug, Dr. Phillips, who's going to be our opening keynote speaker at the summit, is going to in part speak about this very issue. And so what is, are we at a point where we're sort of PCMH 2.0 or 3.0? And so it's a good model. It's the best model we have. And so, but the model is, you figure it was introduced, 2007. So that's been a while. So I think that as we understand more about primary care and the needs of our patients and how we can best meet them, we see an evolution in the model. And so I think what you'll probably hear Dr. Phillips talk about is like PCMH 3.0. What does it look like now with the understanding of the health equity aspect of it, and the integration of behavioral, oral health, substance use disorder, payment structure, much more emphasis on teams, healthcare teams. And I think that the NASM report really has helped us with that. I mean, the NASM report is a very, very helpful tool. And I would encourage all of you, there's an executive summary. It's a pretty long, but it's NASEM. You could just, Google primary care. And so I think a lot of us are saying the same things. It's a matter of getting the folks that make the policy and that spend the money to listen.
And another question actually from Clayton. Can you speak to the rise of retail corporations' attempts to enter into the primary care space? I think this is an interesting question given our consensus panel work and the conversations that have been happening.
Yeah, I mean, it presents some very big challenges. And I think, we talk in Texas a lot about, in other places, but about the independent practices and how important independent practices is. And Texas has been one of those kind of holdout states, if you will, where we probably still have more independent practices than and small practices than many other places in the country do. And so, yes, but now we see the rise, whether it's Minute Clinic or the Walgreens or Walmart or whatever it is, work-related clinics. They have a place. The biggest concern, well, there's a couple of concerns, but one of the major concerns I think has always been and will be continuity and connectivity. So if somebody is visiting another town or it's after hours or whatever it is, and they need to seek care at a different location, a retail location, well, okay, but how do they connect? How do they connect with the primary care practice? Again, we talk about continuity. We talked about longitudinal relationships. So if somebody goes to, and I'm not picking on Minute Clinic, I'm just saying that if somebody goes to Minute Clinic and they get treated for their sinusitis, but your primary care physician office doesn't have a record of that's a problem. And so I think that the truth is they are here. I think there's a lot of money behind them. I think there's a lot of appeal, but you will notice that some of like Amazon is kind of backing away from its primary care initiative. And I think that all of us that do primary care realize it's complicated, and it's based on relationships. And I think if I think about primary care, that's what I think about. That's what I love about it, because it's based on hope, ideally anyway, longstanding relationships. So the retail have a place, yes, and they're probably here to say, but we have to really insist that there is connectivity and communication, collaboration with the primary care office. And the other part of that, Clayton, is, one of the things in the medical home is access. Part of this is on us, and I'll just say that is, if you call your doctor's office, well, we're closed for lunch from 12 to 1, and we're, if you call at 4 and you get the answering service. So access is huge. And I think we have not done as good of a job as we can to help provide access to our patients, more, 24-hour, more broad access. So part of it, we sort of have left a void. Now, not all practices, many practices have really taken up the mantle here, especially bigger practices that have the capacity and the resources to do that. But I think they're here to stay. But again, we can certainly encourage them to connect with us.
Yeah, I think another word is convenience too, because
huge.
I visited an urgent care facility myself a couple of times. And so I think for me personally, that just really points to the vital importance to improve the primary care workforce, as you said, Dr. Bornstein, to better access in that way as well. And let's see, so there was another question that was submitted beforehand that I think would be interesting to answer, of course, too, is please discuss the physician compensation, evaluation and compensation model to support primary care. You talked about this a little bit.
Sure. again, this is in line with the fee for service, is that if physician, and I mean, this is kind of human nature, right? If professionals, physicians are paid by the unit of work that they do, which is basically how most physicians are paid now, with the RVS system. It's about, it's units of work. Well, the more units of work you do, the more money the more income you're gonna have. And so, again, this is human nature. This doesn't mean that people are greedy or anything like that. It's the system. This is the prevailing system. The problem with that is, as we've mentioned, fee for service, it can encourage excessive testing, excessive procedures, and then we really didn't have time to touch on this, but there's a whole topic of high value versus low value care. What is that? Well, there's a lot of low value care, things that cost money and that may actually harm patients. And examples of that are doing routine labs on healthy people that don't really need them. That's kind of low hanging fruit. But there's more. There's, doing a stress test every year on someone who is asymptomatic. And so, or doing a more primary care related example is doing an MRI scan or a CT scan on someone who has acute low back pain, when we know that in 6 to 8 weeks, 95% of people with acute back pain are going to do okay no matter what you do to them or for them. And so that, I think, it really gets into the whole high value, low value care discussion, but the compensation model has to change. It just has to change, and it is changing. But the problem is, it's sort of, we have one foot in the door and kind of one foot in the other door, and then there's this gulf in the middle. And so it's tough. It's a tough transition from fee for service to more value based, sort of population based. Practices are paid on the basis of the population that they care for, whether it's a per member per month type payment. There's certainly incentive bonuses. And so, yeah, in my opinion, and it's primary care in particular, for some specialties, okay, they can, fee for service seems to work for them, for more procedural specialists, but for the more cognitive based specialists, it's just not a good system. So we need a new payment system. Long answer to a short question.
I agree. And I think we have time for one more question. So I think talking about the rural community, the question comes from Tamara Meyer. Have ACOs started to move into rural communities to assist in increasing practitioners in those areas?
Actually, yeah, they have. And I know this in particular, and I mean, not so much maybe rural, but in the lower Rio Grande Valley, there's some of the more successful physician-led ACOs are actually in the RGV. And so, yeah, I think that it can be the challenge, as you pointed out, Nishi, is, you have to have, for an ACO to operate, you need to have a hospital, right? You need to have physicians and other healthcare professionals. And that's the lack of those. And you look how many rural hospitals have closed their OB units. That is very scary, right? Somebody lives way out in West Texas in the Big Bend country, and they have to drive an hour or more if they're in active labor. So you have, I think it starts in a rural community with adequate workforce. That's a whole nother challenge. How do you get people there? And I think, our medical schools have done a good job. I have to give a shout out to the University of North Texas osteopathic school, that they have an office on rural health. And they really encourage their students to do rotations there and to even do part of their residencies there. So you have to expose people, but it starts with the healthcare workforce, I think, before you can really move to an ACO model.
Thank you so much. And thank you everyone for joining us today. This has been, and I see actually some more questions coming in, but this has been a really great and wonderful discussion. As Dr. Bornstein said, we would love to come back in the future with some more webinars, of course, with some more information sharing. Just a note that you will be receiving a recording of this and also the PowerPoint slides after this Zoom call. There's also an evaluation that we would love for you to complete so that we know what types of information, what more you would like to see from us. And please feel free to reach out with any questions, but if you want to learn more.
Thank you all so much for joining us, and we look forward to future discussions. Thanks a lot.